So, ladies and gentlemen, dear colleagues, let me go very shortly, very briefly from the common report on V4 cards. Then we will have a lunch and we can continue in our discussion during the lunch. So, as we saw the previous picture, it was a tunnel in New York, but we could say that tunnel is here in V4, because with tunneling we call like rubbering the system. And what the starting points in our common report, it is the absence of systemic healthcare reforms in all V4 countries. After the fall of the communism, there was a gradual destruction of the previous system, which wasn't good, but it was something like functioning, and without following a clear definition of the new rules. We can see similarities of unfavorable development in healthcare system in all countries. Similar expenditure on healthcare, that means under-financed health systems. Unsystemic reforms, so-called reforms, under the influence of interest and financial groups. So it's not a reform, that's just the plundering of the system. And we can see the similarity of evolution in this kind of reforms in Slovakia in 2003, 2004, 2011, like in Hungary in 2006, and Czech Republic 2007, 8, and now maybe 2012, and in Poland in 2008 and 2012. It's the very similar laws that create a corruption system and create a place for privatization of the hospitals. As I said, the problem is the corrupt and non-transparent environment. This is the political decision, we have to say it. This is the plundering of system, set up system to profits for some just selected segments. For example, distribution companies, pharmacies, health insurance companies, selected medical segments, for example, X-ray departments, MRI, dialysis, selected laboratory, but with favorable contracts, not in hospitals, but just in private sector. Purchases of medical equipment, other services in hospitals, property management is not good, because we can see non-transparent contracts, just only by political decision. And the final goal is to afford to privatize selected segments of healthcare under the pretext of transformation of hospitals into joint stock companies, as we saw it in Slovakia 2 years ago, and as we saw it in Czech Republic for now. Why it goes this way? Because we have to say in healthcare system is a large amount of finance, and it's not only for 1 year, it's for continuously in every year in future. So if you can get some connection to hospitals or insurance companies, you have ambulance profit in future, in all time. We have to say that health insurance companies do not fulfill its basic function. The fundamental problem of the current system in all countries, I have to say, is inadequate payments by health insurance companies for healthcare. The healthcare providers must provide adequate healthcare, but the health insurance companies have no obligation to pay the real cost of providing healthcare. It means it goes to increasing of gap, cost versus payment by health insurance companies, and then it created so-called healthcare debt. If the health insurance companies have no obligation to pay real cost, it doesn't matter if there is only one insurance company or more insurance companies. So we can see in Poland they have one insurance company, and the situation is the same like in Slovakia. We have more than one insurance company, so it doesn't solve the problem. So the only goal is to pay the real cost of providing healthcare. Doesn't matter from one or more health insurance companies.
Yes, just to comment, the fact or the situation whether to have one insurance company or several insurance company. If you have one insurance company, it is easier to control it, to regulate it. In Czech Republic, for example, we have 8 or 9 insurance companies, and this is increasing the administration or labor intensity of doctors, because they have to communicate with all 9 insurance companies, and this increases administrative time spent during the communication. For example, if you have 9 insurance companies, you have to fill in 9 various types of files or requests for payments, and this increases bureaucracy.
The next problem is the lack of resources for ensuring and development of healthcare, especially in the sphere of healthcare provider, hospitals, and ambulance. We can see reducing the assessment base of health insurance contributions for the insured state in Slovakia, as I said in my previous presentation. Restriction of reimbursement decree in Czech Republic, as reported by Martin Engel from Czech Republic. And it goes to the low proportion of gross domestic product spent on healthcare in every country.
Before I said that there are two ways of looking at the health system, an economical activity or a service. My idea is in favor of the so-called coverage system. I think that healthcare is the same, the national health system is the same as the fire brigade or police or army. It's a system for the protections, for the protection of the citizen. So if we enter in this mechanism of having a public system but with private insurance, so I introduce absolutely a criteria of wild market, because it's not a regulated market, because every insurance makes whatever they want. A wild market inside a public system that is crucial for the population, because it has to is not sport, is health. So I understand that it's very difficult to enter this problem, because it's a political huge decision, because if they want to go to the college system, means that now, from now on, we change and we decide that maybe we make people pay a little bit more taxes, but we cancel all the insurance companies. But after, you must mate with the insurance situation that will cut your fingers if a government does such things, provided that there are particular relation between the politician and the insurance company. So I understand that it's difficult, but I think it's the base to start for a new health system is this one, to go to the college system. That is why we cannot be a hostage of the interest of a private insurance.
So what is the result of this? It is spending on healthcare per capita is insufficient and well below the EU average. So maybe you can see, but it's very in little letters. But there is with red color the average spending per capita on healthcare in EU 27. And you can see there is Portugal, then Slovenia, Cyprus, Malta, and there is Slovak Republic, Czech Republic, Hungary, and Poland. There is spending on healthcare per capita. But there is also the money that are going from pocket of the patients, not in corrupt, but direct payment. So it's not only public resources, but all resources in the system. We can see in the Slovak Republic is maybe much higher than in Poland, but as I said in my previous speech, there is a difference, because we have some out-of-patient money they are spent and they are count in per capita. And if we can compare with, for example, Netherlands, there is only maybe 6% of outpatient money, from money from out-of-pocket of patient, and in Slovakia there is about 30%. It is not intended the range of basic health care paid from compulsory, means public health insurance system, and the superstructure above standard health care financed by commercial insurance or direct payments based but on expert medical arguments. So it's not good if, as Stanislav Urban said, in Poland, there is government said to people, you can take all the healthcare you need, but they don't have to pay for it. So it means we need some clear rules. Yes? Clear rules, what is the payment from public healthcare and what is from the direct payment, because we don't have clear rules about it. The problem in V4 countries is the working conditions of health professionals. We have problems with complaints with the labor code, European Working Time Directive, overtime and standby duties, staffing norms, professional training, attestation training, fair remuneration for the work in all V4 countries. And a special problem in Czech and Slovak Republic is the unwillingness of politicians comply with written commitments. It means a memorandum signed in the Czech and Slovak Republic, which is unfulfilled in both countries. Of course, we have to talk about leaving health professionals abroad for better conditions. We talked about a lot of sentences, so I have not to add something, but I can have a conclusions. There is the reducing the number of health professionals. In Poland, it is 2 doctors for 100 people. In Hungary, each year more than 1,000 doctors leaving the country. And in Slovakia, as I showed in the previous presentation, there is a decline of doctors, despite it was from the 2008, but it continues in this time too. It results to increasing the average age of physicians and a lack of middle generation of doctors. We have to say that the healthcare system, its development and stability is not a priority for the governments for years. Politicians focus on reducing healthcare regardless for the impact on people without a clear vision for sustainable health development. We heard a report from Martin Engel in Czech Republic. These efforts are particularly dangerous for patients and for health professionals who have to work under the ever greater pressure. It means greater pressure from employers, greater pressure from patients. And instead of respecting agreements and finding solutions, governments focus on suppressing the rights of healthcare workers. There is the escalation of political pressure, long-term ongoing negative campaign against health professionals in their requirements for fair working conditions. So what about the solutions? So we find these solutions. Ensure transparency and eliminate corruption from all points of the system. The disclosure of all contracts which are used by public resources of money, it means from taxpayers' money, for health insurance, and punish those who break the law or came to improper benefits. Second, ensure a catalog of performance, ensure a real payment for medical performance determined in accordance with the law on prices, including labor costs of healthcare workers. Third, ensure adequate financial resources from public health insurance. Fourth, determining the healthcare paid from compulsory public health insurance system, and the superstructure above standard healthcare financed by commercial direct payments based on expert medical.
When they to ensure a real payment for medical performance determined in accordance with the law and prices and so on. So in other places we already have the payment of performances according to the DRG system, so-called diagnosis-related system. Payment. But one thing is the value of the performance is arbitrarian. It is not coming from a perfect analytical cost of the so also I had the Italian experience. They made the mistake of using the DRG system as a method of management of the system, while the real problem is the cost. DRG is just a system of financement, but the costs are a different thing from how much you pay. Example, in Italy, for a day hospital, you pay, the hospital, they receive from the sanitary unit, they receive a sum that is half as much as the regular daily, well, not daily, but the real performance, if they give the performance in an inpatient situation. But for instance, if you go to have coronarography in outpatient, and you make coronarography in the inpatient, the first day in outpatient, you have the maximum cost. I mean, the people, the catheter, the drugs, and so on. So even if you pay half of the sum, if they made the same procedure in inpatients, you don't save money in this way. You underfinance the hospital. So it's one must be careful when they decide how to decide on the pre-decided costs of performances, because it can be. In fact, now with the in the historical costs, I think that our system of DRG must be used mainly or only to detect the so-called case mix. So the case mix is the average score that a hospital has starting from the DRG. You have patients who come here for heart transplantation or for a broken nail. So with DRG, you know how much money you get, but you know also what is the level of the performance you give. So a hospital with a low level of case mix must be reviewed, because maybe it's not so necessary to keep the hospital like that. In other hospitals with a high level of case mix, you must see if they need more financing and so on. So it can be used for that purpose. It's dangerous to think to use the payment of DRG as a system for controlling and managing the system. You manage the system only if you keep under control the costs, not the way of financement. So if you see that the costs are kept under control and were kept under control, and you see that the financement is not enough, well, you must change the financement. If you spend more than necessary, well, you must cut the costs. But so it must be done in comparison with the real costs of procedures, and not with the kind of financement you give.
So that's the reason we are talking about the law on prices. So determine the prices according to the law, not according just something might. I think it's the fifth. Improve the working conditions of health professionals and thus stabilize them in their home country. It means comply with labor code and fair remuneration for the work of the healthcare professionals. And the sixth is insurance adequate and sufficient space for the professional and trade union organization of professionals in the system, respecting their comments and allow them to actively intervene in the system settings. And of course, stop the discrimination and persecution of their representatives at all levels. And the seventh, comply with the standards and transparent rules for the functioning of the system, and violators must be excluded from the system. It's the last slide. I have to say that we are here because we want to improve the healthcare. We have the same problems, we share the same problems, and we all know that the sick healthcare system is a threat for everyone, and we want to change it. Thank you very much.
Tak, aby som zakončil svoju prezentáciu, vidíme, že všetky krajiny V4. Ďakujem veľmi pekne.